In frontline, FCR treatment is still the standard of care in the UK and in many other European countries. We have got a lot of new targeted agents available now, and there's clearly an assumption that at least for some patients these new agents will become available also in frontline in Europe. However, the recent German FCR data has shown that a significant proportion of patients with CLL who have a hypermutated immunoglobulin rearrangement are probably cured by FCR treatment in frontline. So on the other hand, on the other side of the spectrum, you see patients treated with FCR, 25% of them will relapse within the first 2 years of having received chemoimmunotherapy, often with significant toxicity and side effects from the treatment. So really we need to identify those patients and those poor risk patients. These also include patients with Richter syndrome, where we still haven't got any good treatments, and the overall survival of patients after high-grade transformation is only 8 months. One way of trying to understand what treatment is best for our patients, giving the right treatment for the right patient at the right time, i.e. precision medicine, would be to use molecular markers. We've known for a long time that structural variations such as deletions of 17p, for example, confer poor prognosis in CLL, and we've also known for a long time that mutations in TP53, which is the gene that is located on 17p, also confer poor prognosis, and that's been confirmed by multiple randomized controlled trials. However, we also know from real-life data that actually only about a third of clinicians will request TP53 mutation analysis. So there's a real need educational need to make sure that we are using Sanger sequencing for the mutation detection, and that we're using the FISH for the detection of deletions, to identify those patients in frontline who will benefit from ibrutinib or other forms of targeted therapy. In addition to that, with the advent of next-generation sequencing technology, we have got now a much more sensitive tool to detect smaller subclonal mutations, in particular of TP53. And again, data from the Northern Italian group and David Rossi, and our own data from the Arctic and Maya trial suggests that patients with subclonal TP53 mutations have an equally bad prognosis to patients with clonal TP53 mutations. And so they also relapse within a 2-year time frame after chemoimmunotherapy. That increases the number of patients who relapse within 2 years, and we know of, from roughly about 4% using just FISH alone, to almost 20% if you're using next-generation sequencing combined with a deletion analysis. So one important message, I think, is that the improvements in diagnostic technology actually make precision medicine more precise. The other thing that we found is, again, using next-generation sequencing, is that there are other genes like SAMHD1, RPS15, also the mutations in those genes also associate with short relapse-free survival in the clinical trial setting. So we've got a number of mutations now. We've got subclonal mutations, number of mutations in different genes, and so we should start to use this technology, the NGS technology, to basically identify those high-risk patients who we know won't benefit from FCR treatment.